Welcome to the deep dive. Today we're cutting through the complexity of antiprotozoal agents.
The big one.
It is, and it's a really critical deep dive because, we often associate these infections with places far from home.
Right. Developing nations, poor sanitation, tropical climates.
Exactly. But they're becoming more and more relevant for anyone who travels, or really, for anyone providing care in a world where things move so fast.
Absolutely. So to get the drugs, you first have to understand the bug.
Okay.
Protozoa are single-celled organisms, but they're not simple at all. They have these really sophisticated life cycles, and part of that is a parasitic phase in humans.
And we tend to group them by how they get to us.
Basically, yeah. Either from an insect bite, think malaria, trypanosomiasis, or from, ingestion or direct contact.
Like amebiasis or giardiasis.
Exactly those.
So before we even get to the specific drugs, it sounds like there are some major safety rules that apply across the board.
There really are, and it starts with our youngest patients. Children are just. They're extremely sensitive to the adverse effects.
And we don't always have the best data for them.
We often don't, so if a child is traveling somewhere endemic, you need specific advice. You consult the CDC. That part is non-negotiable.
And what about adults? Pregnant or nursing women, for instance? That seems like a huge red flag area.
It's the tightest restriction. I mean, these drugs have significant teratogenic potential.
They can cause birth defects.
Serious ones.
Okay.
So the rule is you only use them if the benefit massively, and I mean massively, outweighs that known risk. And for women of childbearing age, strict barrier contraceptives are mandatory.
And for adults, taking them as a preventative.
They just have to be rigorous about it. Mark your calendar, set an alarm, you can't miss doses.
And for older adults, what's the main concern there?
The liver. Always the liver. Hepatic function can decline with age, and since these drugs are metabolized there, you can get toxic accumulation really fast.
So you might need to lower the dose.
You often have to, yeah, especially if you see any sign of hepatic dysfunction.
All right, let's zoom in on the biggest one then. Malaria. I mean, this disease has shaped history.
It really has, and it's only transmitted by one thing.
The bite of the female Anopheles mosquito.
That's it. And the modern challenge is that we're fighting on two fronts now.
How so?
The mosquitoes are becoming resistant to our insecticides, and the parasite itself, the Plasmodium, is developing resistance to our drugs.
So to treat it, you have to understand its life cycle. It's almost like a stealth operation at first.
It is. The mosquito bites, and it injects what are called sporozoites.
The first stage.
The very first stage. They travel right to the liver and other tissues, and they just hide. They multiply asexually inside the cells. We call them tissue schizonts.
And while they're feeding, they're called trophozoates.
Right. They're using the cell's nutrients.
Yeah.
This is the silent phase. No symptoms.
But then the silence breaks.
It does. After about a week, maybe 10 days, those schizonts rupture. They burst open and release the next stage, the merozoites, into the bloodstream.
And these go straight for the red blood cells.
Immediately. They invade the RBCs, they replicate again, and then boom, the red blood cells burst.
And that's the acute malarial attack. That's the chills and fever.
Exactly. It's a massive inflammatory reaction to all that cellular debris. And the timing of that fever, that cycle, tells you a lot.
Usually every 72 hours, right?
Corresponds perfectly to a new generation of red blood cells rupturing.
Now, we always hear about P. falciparum. Why is that one so feared?
Because it's just so aggressive, it's acute, it's fast, and it can be deadly. It destroys so many red blood cells that the debris can literally clog small blood vessels.
To the brain, to other organs.
Right. The one sort of good thing is that once you clear the acute phase, it usually doesn't relapse.
Unlike the other types like PV-Vax, which are milder but sneakier.
They are. PV-Vax and P. malaria are tricky because their schizonts can lie dormant in the liver for months.
Or even years.
Or years. And then they can just emerge later and cause a whole new attack. That's why the treatment has to be long-term for those specific types.
So the whole treatment strategy is about combination therapy. You have to attack the parasite at all its different life stages.
You got it. We need drugs that are schizonticidal. That's for the acute red blood cell phase, but also gametocytocidal and sporontocidal to stop the whole cycle.
Let's talk about the mainstay, chloroquine.
Okay, so chloroquine is fascinating. It gets into the red blood cells and it changes the metabolic pathways, which basically stops the parasite from making the DNA and protein it needs to reproduce.
It scarves it out, in a way.
In a way, yeah. Then you have mefloquine, which works a bit differently.
How so?
It increases the acidity inside the parasite's food vacuoles, so the parasite can't digest nutrients and the cell just ruptures.
And of course, there's quinine, the original.
The very first.
Yeah.
It inhibits nucleic acid synthesis, but you have to be careful with it.
Because it's synchronism.
Synchronism, right. That classic toxicity, nausea, vomiting, vertigo, and the big one, tinnitus, ringing in the ears.
With resistance being such a problem, we're relying more on combinations. What are the key ones?
Well, for P. falciparum resistance, we often use malarone, that's adovocone plus proguanil. And for an acute, uncomplicated infection, we use Cortem.
Okay, let's stop on Cortem. There's a critical safety alert here.
A huge one. Cortem is known to prolong the QT interval on an ACG.
Which is a major risk for a life-threatening arrhythmia.
It is. So you absolutely avoid it in anyone who already has QT prolongation or is taking any other drug that could also extend it. That is a hard stop, a non-negotiable safety check.
We also use certain antibiotics sometimes, don't we?
We do. Doxycycline, clindamycin. They get paired with quinine to fight off the really tough resistant strains.
Okay, moving into nursing safety, what are the absolute contraindications for these drugs?
Well, besides allergy, you're looking at severe liver disease or alcoholism. That hepatic metabolism is a requirement. And like we said, pregnancy and lactation are almost always off the table.
Now, let's talk about a critical genetic issue. This is where a cultural assessment can literally save a life. G6PD deficiency.
Yes, this is a major, major clinical trap. Patients with Greek, Italian, Mediterranean, or African-American heritage have a higher chance of having G6PD deficiency.
And if they take chloroquine or primaquine?
It can trigger a massive, life-threatening destruction of their red blood cells, a hemolytic crisis. You have to screen for it, or at the very least, monitor them incredibly closely.
So what are the key adverse effects we're monitoring for? The ones that make us stop therapy?
Beyond the usual GI upset and dizziness, you are watching the eyes and ears.
Okay.
These drugs can cause visual changes, even permanent blindness from retinal damage. And they can cause ototoxicity hearing loss, that ringing in the ears, which signals deeper CNS toxicity.
So your baseline assessment has to include ophthalmic and auditory exams.
It's mandatory, and you have to teach the patient.
What do they need to report?
Immediately report any blurry vision, any hearing changes, or if their fever comes roaring back, that could mean a resistant strain.
Let's pivot now. Let's talk about the other protozoal infections, the ones you might get from contaminated food or water.
Good transition. Let's start with amebiasis, or amoebic dysentery. That's from Entamoeba histolytica.
You ingest the cyst.
Right, from contaminated water or food. In your large intestine, it turns into this tissue-dissolving form called a trophozoate.
And these things literally chew through tissue.
They do. It can cause awful diarrhea or even invade the liver or the brain.
And for that, our go-to drug is usually metronidazole.
For the intestinal form, yes. For the extraintestinal forms, sometimes we'll use chloroquine.
And then there's giardiasis.
Right, from Giardia lamblia. It's the most common intestinal parasite here in the U.S.
And it has that one unforgettable clinical sign.
It does. The characteristic rotten egg-smelling stool, it's very distinct.
And the treatment there is also metronidazole or something similar.
Often, yes. Metronidazole, tinidazole, or nitazoxanide.
Okay, and just quickly, what about the more exotic infections, leishmaniasis and trypanosomiasis?
Right, so leishmaniasis comes from sandflies. It causes these horrible lesions on the skin, mucous membranes, or even internal organs.
And trypanosomiasis.
That's two big diseases. African sleeping sickness from the tsetse fly, which causes CNS inflammation, and Chagas disease from a type of housefly, which is notorious for causing really serious damage to the heart muscle.
And what do we use for those?
Systemic pentamidine is one option, and benznidazole specifically for Chagas, especially in kids.
We also have to touch on PJP.
Pneumocystis jirovecii pneumonia. Yes, it's important because it's technically a fungus, not a protozoan.
But it acts like an opportunistic infection.
Exactly. It's the most common opportunistic respiratory infection in patients with AIDS. We often treat that with inhaled pentamidine or oral etavoquone.
So for most of these non-malarial drugs like metronidazole, the mechanism is about blocking DNA synthesis, right?
Yeah.
Stopping reproduction.
That's the main mechanism, yes. It leads to cell death.
So metronidazole, the prototype, what are the key side effects to know?
Besides the usual GI upset, patients often complain about a really distinct, persistent metallic taste.
I've heard that.
Yeah, and it can also cause a harmless darkening of the urine. But now we have to hit the single biggest safety warning for this whole group of drugs.
The major interaction for metronidazole, tinidazole, and benznidazole.
This is the one teaching point you absolutely cannot miss. These drugs must never be combined with alcohol.
And why is that? What happens?
It causes a severe disulfiram-like reaction, intense flushing, headache, severe nausea and vomiting. It's a dramatic, awful reaction.
And patients need to avoid all alcohol.
All of it, including things you might not think of, like mouthwash. And they have to avoid it for at least 3 days after they've finished the entire course of the drug.
Wow, okay. Are there other big interactions to watch for?
Yes. Be very cautious combining metronidazole or tinidazole with oral anticoagulants like warfarin.
Increases bleeding risk.
Dangerously so. And you also avoid giving it with disulfiram itself because of a risk of psychotic reactions.
So let's bring it all home. What are the final overarching nursing points for any of these antiprotozoal agents?
Number 1, make sure the patient completes the full course, even if they feel better.
Don't stop early.
Never. 2, monitor their CNS function, watch for ataxia, peripheral neuropathy, warn them about dizziness, so no driving.
Right.
And finally, a simple tip. Taking the drug with food can really help with that GI upset and the metallic taste.
This has been a really comprehensive look at a global pharmacologic battlefield. Let's try to boil it down to the absolute key takeaways.
Okay. First, protozoa have complex life cycles, so you need tailored treatments.
Got it.
Second, for malaria, remember combination therapy, checking for G6PD deficiency, and monitoring for retinal damage and QT prolongation.
And third,
For the others, like amebiasis, drugs like metronidazole are key, but the absolute mandatory avoidance of alcohol is critical for patient safety.
and that brings us to our final thought for you, the learner. Think about global travel. Think about how fast things spread.
Right.
Given how much people move around the world, how does the rise of regional diseases, especially drug-resistant ones, fundamentally change how you have to approach community health and your own nursing practice, even if you're thousands of miles away from the tropics?
Your clinical scope is now global, a really compelling challenge to consider. Thank you for joining us for this deep dive.
We'll see you next time.